Thank you. My name is Father Eddy Eustache. I'm a priest, a psychologist, and I direct mental health services in Zami La Santé, a community health delivery organization that has been working in Haiti since 1983.
My name is Bepi, Raviola. I'm a physician, I'm a child psychiatrist, I'm an adult psychiatrist, and I direct mental health for Partners in Health. I have worked with Father Eddy and the team in Haiti for the past 7 years, working on developing mental health systems. Father Eddy and I met in 2009 in Rwanda. Father Eddy has had a role traveling across all of the Partners in Health sites, supporting staff. So we met initially in Rwanda and then started working together with the earthquake in 2010.
We're here today to celebrate partnerships. All kind of partnership that can change the world. In Haiti, we have a saying that means, in Creole we say, "Main en pile, chai palou." That means in English, many hands make light work. Global health is a difficult work, and the sum of our efforts must be greater than the parts. We celebrate partnerships with capital P, like the one we have with +1, with Arcade Fire, between PIH and Zami La Santé in Haiti, that are critical, partnerships that are critical to our ability to move mountains, to do difficult work together, and to provide care to people, the ones who are the most in need. The PIH work is all about social justice. Social justice through what we call the preferential option for the poor. It is a way to prioritize the best quality of care for the most vulnerable people. The model of PIH is built on free medical care and in addressing all the social determinants of illness, particularly poverty in all its forms. We build hospitals. We link care to the health centers in the communities in addressing all the issues facing by the people. And as well, we engage community health workers to provide to the people, to the families in the community that are affected by illness and poverty. What we do more, we work in the most difficult countries, in the most difficult situation. For instance, in Rwanda, where in 1994, a genocide took the lives of 1 million people. In Lesotho, where we have the lowest life expectancy, where in Sierra Leone, where Ebola terrorized communities and families, and where people have the highest rate of maternal mortality in the world. And mostly in my home country, in Haiti, where within one afternoon, the earthquake on January the 12th, 2010, killed more than 300,000 people in a few minutes. What we had to do in front of that? We tried to make a strong commitment to working with people and trying to make an impact and finding ways to work not only in the individual life, but as well in trying to work with government health ministries and trying to strengthen health systems. For instance, in 2013, we built a state-of-the-art of academic hospital where the quality of care that is served has transformed us, has made us in Haiti the main referral center in Haiti. We managed as well to have this hospital as a place where early career professionals can receive training in a supportive and academic institution where the environment is appropriate for that.
So Partners in Health, we work across 10 countries. We have 18,000 staff, mostly local. And the organization was built really to address terrible infectious diseases such as HIV and tuberculosis, as well as the poverty that feeds those diseases. But what's happened over time is that we've seen a lot in terms of unaddressed mental health problems. And so while Partners in Health started as its core as an organization addressing infectious diseases, through the 90s and 2000s, that process really led to the strengthening of public health systems and primary care systems. And that is now enabling us to confront other kinds of issues, non-communicable diseases, diabetes, heart disease, cancer, and mental disorders. We know that mental disorders present a huge burden to societies. We know it through epidemiologic data and other kinds of data that show us that of all conditions, in terms of years lived with disability, mental disorders are the biggest burden. In fact, greater than HIV, AIDS, and TB, greater than malaria and other tropical diseases, greater than heart disease. So mental disorders comprise a big part of the global burden. We're talking about mental health problems not just as stress-related responses to extreme poverty or disasters or conflict or genocide, but we're also talking about mental disorders that exist across all cultures: depression, psychotic disorders, alcohol and substance use disorders that also feed domestic violence, child developmental disorders, and other disorders. Where we work, and this really cuts to the heart of what we wrestle with in our mental health work, we work in places where there are no mental health providers. In Lesotho, which Father Eddy mentioned, which has an HIV rate of 25%, a population of 2 million nestled within South Africa, there's no psychiatrist. In Sierra Leone and Liberia, in West Africa where we work, where Ebola presented itself a number of years ago, there's not more than one psychiatrist working in each of those countries, local psychiatrist. In Haiti and Rwanda, where we work, each with a population of 10 million people, there are approximately no more than 5 psychiatrists and 2 neurologists working in the public sector. So we're presented with an incredible challenge in terms of delivery. And so we spend a lot of our time thinking about solutions to delivery, especially when governments give so little money to mental health. If mental health comprises 15% of the global burden, ministries of health tend to spend less than 1% of their budgets on mental health, and those tend to be focused in locked psychiatric units. And also, if we look at development assistance for mental health, it's also almost non-existent, even though we know that mental disorders have a significant negative impact on economic productivity and on sustainable development in societies. So what we have been doing is trying to use novel techniques, which science is showing in global mental health, that community-based solutions are viable. For example, employing community health workers and having community health workers identify and screen people in communities living with mental disorders, providing support at a household level, and also referring people into emerging systems of care. In Rwanda right now, we are working with government nurses who work at satellite health centers, and we have almost 4,000 people in care, most of that care being delivered by generalist nurses working at health centers. We've also focused significantly on mentorship and training and professional development of specialists, such as psychologists. This is Père Eddy here in the back with our psychologist, Zami Lasante, and also psychiatry training. This year we're hoping to open a new psychiatry residency program in Haiti.
I'd like to share another expression we have in Haiti with you this morning. Petit petit, oiseaux fait niche lit. Little by little, the birds make their nest. You probably heard about the earthquake in 2010. But in the meantime, you probably have been wondering how things have been going since. And what we did, we managed to develop a very caring system where we tried to build another community-based approach where we are trying to replace the terrible locked psychiatric system hospital where human rights abuse are pretty common. We as well manage to see how we can improve this system, and because this psychiatric model reminds us the vestiges of colonialism. We made it our goal as well to deliver a community-based approach, as I was talking about, to go to the families, to meet the individual and help them overcome mental health problems. In doing that, we have been working with community health workers who committed themselves to providing support not only to individuals but as well to the families. Look at this young man. His name is Menardi. He was 23 years old when he started to hear voices. He was almost killed in a ceremony of exorcism within his church by the pastor. And then he was taken to the hospital I spoke of earlier. There he met a psychologist who managed to visit him at home. And then he received psychotherapy. He received medication, and he recovered very quickly. Today, he remains healthy. He developed a radio station that continues today. We have about 4,000 people who are receiving mental health care in the Zambia Santé system. Maybe can you say a word about your last visit with Menardi?
We had a team workshop last week, and I didn't notice, but Menardi actually has developed a radio station in the back of his house, and he makes advertisements and commercials, and he was our AV and DJ for this event, and so it's really nice. So what we've tried to do is make delivery of packages of mental health care comprehensible. We've drawn from global scientific evidence, and we've drawn from the experience of other organizations and our own experience to try to articulate the most basic elements of packages of care that can be delivered, as we've discussed, by non-specialists. And basically, we've developed a functional and sustainable mental health system. I think at this point we've delivered tens of thousands of mental health services, and as Père Eddy said, we have around 4,000 people in Haiti receiving care. But this involves case finding, engagement, and follow-up at a community level. It involves schools and teachers. It involves churches, and it involves community members. Targeted psychological interventions delivered by early career psychologists and social workers and some community health workers, medication management delivered by physicians. We've developed a fellowship in global mental health delivery at Harvard for early career US psychiatrists to work with physicians and live in Haiti with our teams. And then we've also built capacity within the programs and the teams to measure outcomes, to supervise, to teach, and to monitor quality in the system. So this would be a very practical illustration of how a community health worker would be talking with people and screening for mental health problems. And we've also built in increasingly more of a life course approach where we have to marry prevention to treatment. It can't all be intervention. We have to be working with children and families. We can't just be working with individuals, but we need to be thinking about things in terms of families and household level. So maternal depression is a very interesting and important example of that, where untreated depression in a mother can affect nutritional outcomes in the child. So we want to treat and work with the family as a whole. And so all of this taken together, I think when you look at emerging global evidence around the viability of community-based approaches to mental health care delivery that don't depend on hospitals and that de-emphasize medications and really focus on psychosocial approaches, educational approaches, psychotherapeutic approaches, and in certain instances, medication. And then when you look at practice-based evidence of organizations working in this area and our own experience, I think we have a clear argument at this point that we can be delivering mental health service in communities. And of course, when you think about our own mental health system, the fact that while we have 40,000 psychiatrists in the US, we still remain fragmented and we have challenges in delivery and how people access care. There's some really interesting questions. So we have to find ways to bring together lessons and practices from high, middle, and low-income countries. A great teacher of public health, Julius Richmond, he used to talk about 3 essential strategies to effectively building public health systems. He talked about knowledge, he talked about social strategy, and political will. So we're at a very interesting point now with global mental health, where we actually have the knowledge. We know that we can deliver services. In terms of strategy, we know that these packages of care can be delivered. There's the issue of technology, whether it's internet-based, cell phone-based, tablet-based. How do we mobilize technology to also support the use of these packages of care? The issue of political will is the most important one at this point. And so Father Eddy and I, we just want to end with a plea that we find ways to mobilize the political will, to bring together the kinds of strategies and the technologies that we know work and that we can harness these technologies to improve lives through starting in our own country to think about novel ways of delivering mental health services. Thank you.